Good morning, people. We are excited to start this academic year of nephrology grand rounds with Dr. Massicotte-Azarniouch. He is a nephrologist at the Ottawa Hospital, an associate scientist at the OHRI, and an assistant professor at the university. He's been on faculty now for a few years, and he's done a fellowship in Ottawa, but also he's got a master's in epidemiology and did a year of GN training at UNC. And he's really interested in ANCA-vasculitis specifically and trying to minimize the harm that we do to our patients. Welcome, David.
All right, thanks so much, Swapnil. Thank you for allowing me the opportunity to talk about ANCA-vasculitis and some trial that we're about to start up here. So this is a great venue for that. So thanks very much, and to be able to kick off the academic year this way. All right, so I don't have any conflicts of interest relevant to this talk. And the outline, what we're going to go over is ANCA-vasculitis, but really from a renal and nephrologist perspective. There might be some rheumatologists that are on the call, but I'm really going to be focusing about a lot of studies in renal ANCA-vasculitis. So we're going to really look at induction therapy and in particular glucocorticoid reduction. We'll look at evidence from the major trials and some kind of real world observational data on GC reduction and outcomes and different types of strategies that have been that are in development, let's say. So there's complement blockade and also the retux cyclophosphamide combination. We'll also talk about improving renal outcomes and evidence from trials, in particular plasmapheresis and avacopan. I'll briefly talk about, I guess, our guideline or our induction therapy recommendations here at the Ottawa Hospital. And then we'll cap it off with some talk about the SAFE-FLOW trial, which is a randomized trial that we are about to start up here in Ottawa. So I thought I would start with just a sort of timeline on induction therapy. And really the focus initially was controlling disease. And so the first cases of ANCA-vasculitis were reported in the 1920s and 30s. And they basically, it was pathologist, Wejner was the pathologist who saw patients that had these chronic febrile illnesses and kind of destructive sinusitis and severe glomerulonephritis. And that's where it got that name, and eventually found that there were granulomatous infiltrates with angiitis, so called it granulomatous polyangiitis, and MPA, which it took a while to actually get the terminology of MPA. Polyarteritis nodosa was recognized at that time, and what MPA was actually found to be was a microscopic form of polyarteritis nodosa. And eventually they found out that it was a distinct disease and it got the terminology of microscopic polyangiitis, but initially it was a microscopic form of polyarteritis nodosa. So initially these were very kind of, fatal diseases that we couldn't do much about. And then came along glucocorticoids. That came on in the 1950s, and finally you had something that, you had a disease that was pretty much invariably fatal that we were able to control with glucocorticoids. The only issue is that they were using a lot of steroids, for months and years, sometimes very high doses, and even then it wasn't controlling perfectly. And then came along cyclophosphamide in the 1960s or so. And interesting about cyclophosphamide, many know, but some might not, it's actually derived from nitrogen mustard, which was chemical warfare from World War I. And what they saw was that soldiers that had died of exposure to nitrogen mustard had bone marrow suppression and lymphoid tissue suppression. So when they saw, severe and fatal autoimmune diseases like ANCA-vasculitis or lupus nephritis, they started thinking of ways that they could treat these patients with a derivative of nitrogen mustard. And actually that's cyclophosphamide. It's a prodrug. It gets metabolized to the liver into a form of a phosphoramide mustard. So that becomes the toxic agent. So you had something that you could add to glucocorticoids and that could provide a much better disease control. But again, the issue was a lot of cyclophosphamide, and that's where we hear a lot about the various side effects and the terrible things that can happen when you're taking cyclophosphamide for years, sometimes at very high doses. In the 1990s, there was a European trials group of, I guess, investigators with interest in ANCA-vasculitis that came up with a sort of standardized way of using glucocorticoids in ANCA-vasculitis, and that became the I guess standard of care for the next few decades for glucocorticoid use in ANCA-vasculitis that was used in a bunch of trials that were done by the European Vasculitis Society. In 2009, the Cyclops trial, you kind of had around the 2000s and 2010 a shift towards, not necessarily finding ways to get better control, but to decrease toxicity. And that started with Cyclops, where they looked at using lower exposure IV cyclophosphamide versus PO, and they found there were similar results for efficacy. And then, of course, rituximab in 2010, so an alternative agent to cyclophosphamide that targets B cells and the CD20 B cells producing the ANCA. Then, of course, there's PEXIVAS. That was the first trial to actually study specifically a reduced glucocorticoid exposure in patients with very severe disease. Shortly after, you had LOVAS and then ADVOCATE. LOVAS studied an even greater reduced GC exposure in more moderate severity, and then ADVOCATE with avacopan, the complement inhibitor, in patients with moderate severity. So then you see that there's been, I guess, kind of a flurry of studies that have been looking at ways to get away from glucocorticoid exposure and glucocorticoid sparing therapies. And then there are a bunch of others, and then we'll talk about that. One thing that I found quite, I guess, sobering is looking at renal ANCA-vasculitis. Outcomes are actually pretty poor, despite the fact that you have fairly high remission rates. So if we look at renal ANCA-vasculitis, the big trial that for patients with severe renal ANCA-vasculitis is the PEXIVAS trial. It was a huge trial, and nearly everyone had renal involvement, and quite severe. So their creatinine at baseline 330, so that's very, very abnormal. And 20% required acute dialysis, and there were 14% of patients that died. And at 1 year, 30% had end-stage kidney disease or were dead, which is a massive amount. Now, if you think that that's a trial that might not be representative of the, regular practice, when we looked at it at the Ottawa Hospital, we looked at all our cases of biopsy-proven ANCA vasculitis from 2010 to 2023. So 138 patients. Baseline creatinine was 245. And again, nearly 20% required acute dialysis on presentation. 10% died, and 23% had end-stage kidney disease or death at 1 year, which I don't think, I think it kind of, hit me maybe a bit stronger when I saw these data that nearly 1 out of 4 patients, when you're seeing them, there's a possibility that they could have end-stage kidney disease or be dead at 1 year, which is actually quite, stunning that there's such bad outcomes. And like I said, remission is really not the issue. In our cohort, so when we looked at remission, and we define remission as being in remission, but like achieving remission, but being alive and having renal survival at 6 months. So you have a bit over 60% of patients that achieve that. But when they don't achieve that, it's because nearly all of them have either died or they got end-stage kidney disease within 6 months, or they got remission later than 6 months. There's very, very, very few patients that do not achieve remission. So, to me, this tells us that remission is not the main issue. Sorry, remission is not the main issue in ANCA-vasculitis. And I'd argue that, if you have someone who's in remission, but they're on dialysis, that's not a good outcome for that patient. And so we have to be thinking about more than just getting them in remission. I mentioned there are very high rates of death in patients with ANCA-vasculitis. So what are the causes of death in patients? This is data from UVAS trial, so European Vasculitis Society. And they looked at, it was about a bit over 500 patients that were enrolled in about 4 different trials that were led by the European Vasculitis Society. This was around, the early 2000s, from 2000 to 2010. And as we can see, infections were a major contributor to mortality, more so than vasculitis. In the first year, about 50% of patients of deaths are due to vasculitis. And then after 1 year, about 20%. And these numbers are greater than the amount of patients that are dying due to active vasculitis. Of course, this is an older patient population, so other causes of death are going to be things you see in older patients, and that's cardiovascular disease and malignancy. So we see that, later on after the first year, cardiovascular disease starts having an important proportion of the number of deaths, as does malignancy. Now, cardiovascular disease, yes, they're older, and so they can, people die of cardiovascular disease. That's the leading cause of death. But also, residual chronic kidney disease from vasculitis and treatment side effects can contribute to this as well. When we look at specifically renal ANCA-vasculitis, so again, taking data from PEXIVAS and from our TOH cohort. So in our TOH cohort, the first year of follow-up, 10% of patients died, and infections were responsible for about 30%, and vasculitis about 1 out of 3 here. But then on long-term follow-up, so this is throughout the whole follow-up, we see that infections, again, about 30% is due to, of deaths are due to infections. We have a bit more cancer here, cardiovascular. To be honest, I'm a little bit surprised that there wasn't more cardiovascular. Perhaps some of these unknown where we weren't able to determine what the exact cause was. It was in fact cardiovascular. But when you look at PEXIVAS, again, 20% of deaths are due to infections. And then you have a bunch of others, PE, MI, cerebrovascular disease. Those could count as, cardiovascular. You have a bunch that the cause, it was just other causes and unknown. So it's hard to know how many of these would actually have been cardiovascular disease. But all this to drive home the point that infections are really an important cause of death in patients with ANCA-vasculitis. And, now more so than the vasculitis itself. When you have patients that are able to survive, one of the major issues, though, is that they're left with a lot of organ damage. And long-term, that's a major determinant of, long-term outcomes, how much damage, permanent damage they have from their vasculitis. A lot of that is going to be dependent on the severity of disease. So, unfortunately, that a lot of times is out of our control because that just depends on how late they're presenting, or diagnostic delay, or how late they're being referred to nephrologists, for example, or rheumatologists. But when you have more renal scarring, you're going to have more CKD. And I don't need to remind people here that the more CKD you have, the greater your cardiovascular risk, and so your greater risk for adverse outcomes. And also the use of glucocorticoids might have an impact on organ damage. This again was data from the UVAS trials, so the same kind of group of studies from a couple slides before, and they found that factors that were associated with a high level of organ damage. This is a vasculitis damage index. It's a ridiculously long and kind of very detailed questionnaire that's used in trials, but that basically is meant to capture all the various organ systems that have damage due to prior active disease or persistent active disease. It just tells you how much, organ damage a patient might have. And what's significantly associated with that, with higher levels of damage, so GFR. So the greater your GFR, the lower your risk of long-term damage. That, again, leads into CKD and complications that happen with CKD. Also, glucocorticoid use. Now, obviously, you might say that this is confounded by the fact that patients that use more glucocorticoids, it's because they have more persistent disease and they will have more damage because of that. But you can also logically say that, it's possible that glucocorticoids, through their adverse effects and increasing infections, can lead to long-term organ damage as well. So to me, the ways that we can improve outcomes in vasculitis, again, remission is not the way to go. Again, that's if there are rheumatologists on the call, I know that in rheumatology it can be quite different. You can have more kind of resistant, refractory, relapsing disease, but this is looking at it at a perspective of renal vasculitis, which is what we see most of here in nephrology. So treatments work really well. When you have, 80 to 90% of patients that are going to achieve remission, it's kind of hard to find something that's going to do that better. Those are pretty high rates. And major relapses are really not that common anymore with rituximab that we're using. Yes, they can have minor relapses, but major organ-threatening relapses are becoming less and less common. So again, disease control doesn't seem to be the main issue. It's really trying to decrease infections, decrease treatment-related side effects, and improving kidney function, perhaps through better renal recovery. To me, those are the major important outcomes we have to look at in ANCA-vasculitis. Now we'll talk about GC reduction, and of course we need to talk about the PEXI-VAS trial. It was the largest trial in ANCA-vasculitis, and again, a reminder, so 700 patients, severe renal or pulmonary, but nearly everyone had renal involvement, and this is basically like one of the most severe patients that were studied in a trial in ANCA-vasculitis. And they were treated with rituximab or cyclophosphamide. The vast majority were cyclophosphamide, maybe about a quarter were rituximab, and that's just because of the time frame when the trial occurred. There was less Ritux availability in various centers that participated. Everyone got methylprednisolone, and then of course there was the PLEX aspect, which we won't talk about now, but I'll get back to later. And then it was reduced glucocorticoid versus standard. So again, this was kind of the accepted at the time standard GC taper that was established from the 90s and the European Trials Group. And this is the two kind of comparisons of the tapers that were used. And you see the cumulative prednisone exposure. This is an approximation. So a bit over 2 grams in the reduced dose and a bit under 4 grams in the standard dose. So you had about a 42% reduction in glucocorticoid exposure. What they saw was reduced GC versus standard GC. There was no difference in the primary outcome, which was end-stage kidney disease or death. You did have lower rates of serious infections at 1 year and a lower incidence rate of this. And GC-related adverse events were not specifically examined in the trial, but you can probably deduce that if you give more GC, their patients are probably going to have less GC side effects. But overall, the conclusion is that reduced GC was not worse than standard GC. You had a decrease in infections. And so PEXI-VAS really became the standard of care for glucocorticoid use in ANCA-vasculitis, and that's now been adopted by all major society guidelines for the GC taper as the recommended initial GC taper in ANCA-vasculitis. The LOVAS trial is, I find, a really neat trial. Probably does not get, I find, enough advertisement for what they did, which I think was really great. So this was a Japanese trial, much smaller and moderate severity disease patients, mostly anti-MPO, so a bit of a more uniform patient population. But as you can see, their starting GFR was a bit over 50. This compares to PEXI-VAS, where the starting GFR was between 15 and 20. So, not quite the same degree of severity. And what they did is they treated all patients with rituximab. There was no methylprednisolone used. And then they had reduced versus high dose prednisone. Now, when you look at the reduced dose regimen, it's actually quite significant reduction in steroids. So they start not at 1 milligram per kilo, but at 0.5 for 2 weeks. Then 0.25 for 2 weeks. And then after a month, they're only on 7.5 milligrams of prednisone a day. That is really not much prednisone. That is a very rapid taper. And then they stay with, I'd say, kind of low doses that are very slowly tapered over the subsequent 4 or 5 months. But overall, it gives them an exposure of 1.3 grams versus a bit over 4 grams in the high dose. So a 68% reduction in glucocorticoid exposure. And again, this was a lower risk population, of course, than Pexivas, much less end-stage kidney disease and deaths, and this goes with kind of the severity of the initial presentation. But what they saw was that disease control, they defined remission as having a BVAS of 0, so no active manifestations of vasculitis, with a prednisone dose that was at least, so no more than 10 milligrams per day. And they found that there were less adverse effects, so adverse events, so less infections. So you had a reduction in serious infections and a reduction in all types of infections, quite significant, so 2 to 3 times less, and also a decrease in GC-related adverse effects as well. So again, this was less severe disease, but they did an even greater reduction in glucocorticoids and found that you were able to have similar disease control, but with a lot less side effects. Then from Pexivas, there were a couple studies that we'll talk about that looked at, I'd say, the real world experience. So observational studies looking at what happens in the real world practice when you're using reduced glucocorticoids. So this was a study done in France, and it was from the French vasculitis study group, a combination of centers where, of clinics where they treat patients in specialty clinics, they treat vasculitis. So they looked at patients that had organ-threatening disease and that were treated with reduced glucocorticoids as per kind of Pexivas or a standard glucocorticoid regimen. And so these are some of the characteristics. Major things that the ones that got reduced were had a bit worse kidney function, maybe a bit more renal involvement. Rituximab, the predominant induction agent that's being used in this population. And when they looked at their cumulative prednisone exposure over 6 months, so it was 2.5 grams, which is probably a little bit, it is a bit more than Pexivas. Pexivas was more at 6 months, was more about, I think, 2 grams or so. And then their standard was a bit higher, so 4.6 grams, but still 46% reduction in glucocorticoid exposure with reduced glucocorticoid. And they had a composite outcome of death, end-stage kidney disease, major or minor relapse, and disease progression. What they found was that the reduced GC actually had worse outcomes. So there was a higher risk for their composite outcome. And even, death or end-stage kidney disease, they had lower rates of death and end-stage kidney disease. I think they had about 4 to 5% of death and 4 to 5% of end-stage kidney disease in all for each of those outcomes. But it seemed to be a bit higher in the reduced GC compared to the standard GC. Severe infections were somewhat similar, and when they looked among the Ritux-treated patients, they saw that the risk for adverse outcomes was the same, and even more so the even greater risk for end-stage kidney disease or death. So kind of interesting, and they kind of concluded that it's maybe a bit of a warning to the use of reduced glucocorticoids, that maybe it isn't as safe as the Pexivas would have shown, despite that Pexivas was a massive randomized trial. Now, kind of concurrently, we looked at exactly the same thing, well, just about kind of the same idea, but not exactly the same thing. So this is, again, our TOH data, and we'll go into a bit more detail on the data that we looked at. So biopsy-proven ANCA-vasculitis from 2010 to 2023, 138 patients in all. And what we decided to do was look at it by era of glucocorticoid use. And this was because we pretty much uniformly adopted the Pexivas GC taper here at the Ottawa Hospital. And if you have kind of any doubt, these are the cumulative prednisone exposures in the pre-2020, so that's the standard GC era, versus 2020 onwards, reduced GC. And you can see that patients, and this is what patients actually got. So we actually calculate as best we could the total exposure of prednisone. And there's about, a 39% reduction in the first month. That's where you're getting probably some of the greatest amount of reduction. And then in the first 3 months, overall 28%. And then from 3 months to 6 months, a 50% Overall, it came out to about a 40% reduction in glucocorticoid exposure, which is, fairly similar to Pexivas. And then when you look at the plex, how many got plex? So this was in the trial period from 2020 onwards until 2023. No one got plasmapheresis, which we probably went too far with that, and we've kind of shifted, and there's more nuance, and I'll get back to that later. But basically, this kind of shows we really uniformly adopted the Pexivas reduced GC taper. Interestingly, patients 2020 onwards, more severe, creatinine is quite a bit higher baseline creatinine than it is in the standard GC era. I'm not sure this might have to do with, COVID era, diagnostic delays in presentation, stuff like that. So I think that's probably what that is. Maybe we wouldn't see the same degree of separation from like 2024, 2025 currently. What we found was that reduced GC was not associated with worse outcomes. When we looked at the primary outcomes, so we looked at a similar outcome than Pexivas, death or end-stage kidney disease at 1 year. Again, fairly high rates of these, but there was no difference in the risk for reduced GC versus standard GC when adjusted for baseline characteristics. Then none of these were significant, though the numbers are a little bit higher for death and end-stage kidney disease, a bit lower for serious infections. Remissions, again, this is remission with renal and patient survival at 6 months, was similar in both groups. And then recovery from acute dialysis, again, none of these were significant, kind of smaller numbers, but you had a little bit more that recovered from acute dialysis in the reduced GC. When we look at the When we look at the change in kidney function, we see that both groups had kind of a steady improvement in kidney function over time, which is consistent with what's seen in most studies in ANCA-vasculitis. It kind of improves most in the first kind of, let's say, 3 months, and then it kind of continues a little bit. Maybe, interestingly, the standard GC, they had this kind of bigger inflection from 6 months to 12 months. Not quite sure what to read into that. It's kind of smaller numbers, but it was, borderline significant for a greater improvement at 12 months in the standard GC. But you see that kind of both groups improve steadily over the first 12 months. So overall, it was kind of similar improvement in GFR, maybe the suggestion that you had a little bit more in the standard GC at 12 months. So overall, we found that there wasn't any worse outcomes with reduced GC. The French study found that there was worse outcomes with reduced GC. So why the difference? I'm not sure. Patient population probably very different. In those France centers, they're mostly treating patients that have a lot of extrarenal manifestations that you might see in rheumatology or internal medicine clinics, whereas here, obviously, it's a more renal predominant. You might have a lot of renal limited, or kind of where renal is the major manifestation. There isn't much of other manifestations. Perhaps it relates to that. Perhaps also the type of induction agent that's used. And, maybe there might be some suggestion that when you have more severe renal involvement and you use reduced glucocorticoids with only rituximab, you might have worse outcomes. This is kind of a subgroup analysis of Pexivas. When they looked at patients that were treated with rituximab induction, they found that there was, a non-significant association for better outcomes with standard GC for their primary outcome. And then when you looked at the low-VAS trial where only rituximab was used, when they looked at the subgroup of patients with a baseline eGFR of less than 50, so this is kind of similar to Pexivas type criteria, again, you found that there was a non-significant association for better outcomes with high-dose glucocorticoids. And then, of course, there's the French data with the rituximab subgroup. Now, when we looked at our subgroups of, only rituximab versus only cyclophosphamide, there was no kind of signal that they did worse, but we were really getting into very small numbers, so can't really read too much into that. But so there is this kind of suggestion about rituximab that it might not be, if you use rituximab in very severe disease, only rituximab, maybe it's not ideal. So I thought we should talk about where the evidence comes from for rituximab in ANCA-vasculitis. And the major evidence comes from the RAVE trial, which was a US and European study of about 200 patients, was placebo-controlled, so it was a very good study. And they examined rituximab versus oral cyclophosphamide, then transition over to azathioprine. Both arms had a standard GC taper, so it wasn't studying glucocorticoids, but again, you had kind of more moderate severity disease patient population, and they excluded patients with a serum creatinine over 350. But what they found overall is that for their primary outcome of remission with no prednisone, it was non-inferior. Higher rates, it did not reach superiority. So overall, the conclusion was that it was non-inferior to cyclophosphamide. Adverse events were similar. So again, infections, serious infections, low rates of death, low risk population, but overall the adverse events were similar between the two groups. The other trial with rituximab that came out at the exact same time in 2010 was the RetuxVas. And people often forget this. It was a very small study, first of all, but people often forget that, yes, it tested rituximab, but the rituximab group actually also got 2 doses of IV cyclophosphamide. And this is kind of where that combination Ritux cyclophosphamide comes from. They compared that to IV cyclophosphamide, then transitioned to azathioprine maintenance. Again, standard GC taper in both arms. More severe disease patient population with lower GFRs and higher dialysis requirement. And what they found was that there was no major difference in their primary outcome of sustained remission at 12 months between the two groups. And then again, adverse events were fairly similar between the two groups. Serious adverse events were similar. Infections were pretty similar. High rates of death, again, high risk population, but similar between the two. And so, these 2 trials are what kind of led to rituximab being recommended as an agent for patients with organ-threatening disease. However, in the KDIGO guidelines, they make the comment and the note here that when you've got, I guess, more organ-threatening, more severe organ-threatening disease, and, for example, serum creatinine of greater than 3.4, so that's 300 micromoles. I'm not sure why they chose this and not 350, because that was the exclusion in RAVE, and they don't go into the exact detail in the text of the recommendation. But basically, they say that you should use rituximab and cyclophosphamide or cyclophosphamide solo agent, but they do not recommend rituximab as a solo agent. And I believe, so this is most likely because it hasn't been well studied in more severe renal disease as a single agent. But they do recommend Pexivas glucocorticoid taper for all patients. Now, we'll talk about the Ritux cyclophosphamide combination because there's been quite a bit of data over the last, I'd say, 5 to 10 years that you're able to achieve lower glucocorticoid exposure with this combination. And a lot of that evidence comes from UK and Ireland. I'd say it's more of a, even though it's recommended in KDIGO, it's a bit of a niche practice to use the combination. Most centers in the US don't. There's a few at UNC and in Boston, there are some centers that use it. And in Europe, it's mostly going to be in the UK and Ireland. But outside of that, most clinics are using rituximab still. But what they did here, so this is an observational study. They just kind of published on their experience of how they use glucocorticoids with this combination. So they had 2 different, sort of protocols where one of them is only 1 week of glucocorticoids. So that's it, just 1 week of glucocorticoids. Another one was 2 weeks of glucocorticoids. And all patients received 2 doses of 1 gram of rituximab along with a sort of a Euro-lupus type IV cyclophosphamide dosing. And again, patients were maybe not the most severe, but had abnormal creatinine, and a few were dialysis dependent. And they found excellent rates of remission with very low amounts of patients requiring reintroduction of glucocorticoids. So at 3 months, at 6 months, at 12 months, high remission rates without glucocorticoids, and they had a very nice improvement in creatinine. So from a baseline of about 30 to about 55 at 12 months. So that's a very nice improvement of 25 points in GFR, which is quite good for ANCA-vasculitis. Their severe infections, 17%, and no new cases of diabetes. And this was lower rates when they compared to kind of historical controls from their center and from UVAS trials. Like I said, there are a couple other places where they do this, the combination. Mass General, they published experience on using 8 weeks of oral cyclophosphamide with 2 doses of rituximab with kind of a faster taper, but then faster upfront taper, but then a slow kind of to the moderate low doses. And in Scotland also, they used the rituximab cyclophosphamide, 2 doses of each. And they found that using this regimen, they were able to get off prednisone in a median of 12 weeks and with only 1.7 grams of glucocorticoids. And again, all these studies show excellent disease control with what we would expect. So rituximab cyclophosphamide combination seems to be a promising avenue for an alternative GC sparing therapy. But if we talk about GC sparing therapies, I just want to talk quickly about the Advocate trial. So again, this was a fairly large trial, but moderate severity disease patients. And what they tested was avacopan versus glucocorticoid with cyclophosphamide or rituximab. Mean GFR, again, fairly preserved, 45, and they excluded ones with most severe. And in patients that started avacopan, they had GC removal at 4 weeks. And here we see the comparison. So the cumulative exposure, it's quite a significant reduction in exposure, 900 milligrams in the avacopan group versus a bit over 3 grams in the prednisone group, so a 70% reduction. And they found that there were similar rates of remission at 6 months, higher rates of remission at 12 months, which perhaps is due to the design and the fact that that patients that were treated with rituximab were not given any maintenance therapy after that initial induction. So this may be, you have to kind of interpret this with caution, but still overall they saw that there was, it was effective using avacopan, and there were, again, if you're going to have such drastic reduction in glucocorticoids, you're going to have less glucocorticoid side effects. Interestingly, though, infections really not that big of an effect for the extent of reduction. So only very mild reduction in infections in patients with avacopan. So if we kind of recap the major studies, trials that have looked at GC reduction in ANCA-vasculitis, what you see from PEXIVAS and LOVAS is that you kind of get the sense that a greater reduction in glucocorticoid leads to a greater reduction in infection risk. But then in Advocate with avacopan, we see that in even, again, a very big reduction in glucocorticoids doesn't seem to translate to as much of a reduction in infection risk. So perhaps, that's the difference of, the pure glucocorticoid reduction versus adding on another agent that you're using for a year that might have immune suppressing effects. So to improve outcomes, perhaps, ways of doing that is further reducing glucocorticoid. Probably, perhaps you'd be able to get lower infection rates. And also, are there ways to optimize induction therapy for renal recovery? And I'll talk a bit about renal recovery before heading back into glucocorticoid and talking about the trial we're starting here. Now, when we speak about renal recovery, I kind of mentioned this earlier, the greatest predictor of long-term kidney function is going to be the baseline presentation of the patient. And that, unfortunately, is a lot of times out of our control, but it's going to be the number of normal gloms that they have on their biopsy, the degree of fibrotic changes, and their serum creatinine. But, we can't control when we're being referred someone for a suspected ANCA-vasculitis. We can control how quickly we biopsy them, but usually that's, the minority of the time, since when you ask the patient, a lot of times something's been potentially going on for 1 year or even longer. What we can potentially work on though, or that is in our control, is improving renal recovery. So like I had mentioned, most is happening in the first 3 months, and then it continues up to a year. And if you look at kind of the data in general, you see that there's an improvement of 15 to 25 points of GFR. Maybe there's, the TOH data, maybe there was a little bit better in standard GC. They didn't see this in PEXIVAS, although, you can argue, oh, there's a little bit of separation here, though it's really not significant. You're maybe talking about 2 points here. So doesn't seem like steroids that it certainly doesn't seem clear based on a large randomized controlled trial that, the amount of steroids you're using is going to have a significant impact on renal recovery.
David, can I ask in these graphs, how are they accounting for end-stage kidney disease? How is that calculated in the?
I believe in the PEXIVAS, they gave them a value of a GFR of like 5 or 2 or something like that. In our study, we actually we didn't include that data point, so it wasn't like included. If they got end-stage kidney disease, it was missing for the rest.
So they were censored when they developed end-stage kidney disease.
Yeah, exactly.
So if you had a bunch of people with end-stage kidney disease, you'd actually look better.
Potentially, yeah. Maybe a different way of doing it but we kind of maybe chose the simpler way. Now, what's interesting, and it's interesting because what came out of Advocate and a sub-study looking at renal recovery, they found that there was a greater improvement in GFR in patients that had more severe kidney function at presentation. Now, this is smaller amounts of patients. They were the ones that had baseline GFR less than 20, but you see that there's a clear separation here in the improvement in GFR that's happening from 3 months onwards. And so, a lot of people jumped on this and said, well, that's greater renal recovery. And so maybe we should use avacopan to improve renal recovery, which would be honestly huge if you had something that could improve renal recovery so substantially. But, I think it's important to look at what's happening in the prednisone group. This is very, very, very unusual. So at 3 months, it just kind of plateaus. It doesn't move at all after that. And when you look at the improvement in GFR, you're going from 0 to, I don't know, maybe 7 or 8 points here. So that's a lot less than what you would expect to see in trials of ANCA-vasculitis with severe renal involvement. And when you look at avacopan, they're improving by 15, which is, fairly similar to what we see in a lot of studies. So it's not so much that avacopan looks greater, it's that the prednisone group here looks really shitty and looks worse than what we see in other studies. So it's maybe a little bit of caution to really jumping on this and saying that avacopan improves renal recovery. If you had that both groups improved to 15 and avacopan improved 25, I think that would be a lot more promising, but this has to be formally tested. Yeah, so it's just a bit unusual that you have such a big separation and that this doesn't improve as much. When we talk about plasmapheresis, we've kind of spoken about this before, the effect on end-stage kidney disease. This is just a little recap. I won't go into too much detail, but a lot of this is from a meta-analysis looking at all trials and plasmapheresis and ANCA-vasculitis, mostly driven by PEXIVAS because by far the largest. But basically what we see when you have worse presenting kidney function, so higher baseline end-stage kidney disease risk, you have a greater benefit for plasmapheresis in reducing end-stage kidney disease at 1 year. So again, this is at 1 year. This is not long-term, but at 1 year less end-stage kidney disease. And the greater the baseline, renal dysfunction, the greater the benefit. That has to be traded off against an increase in serious infections that goes up with worse baseline kidney function. But in general, higher, the worse the baseline kidney function, probably the greater your benefit for PLEX in terms of benefits versus risks. Another sub-study of PEXIVAS, when they looked at the renal recovery, the improvement in GFR, what you see is that patients in the Pexivas group, so in the Plex group in red, had a better early improvement in kidney function. This might be due to some patients with presenting with dialysis that are more likely to recover from their kidney function. Again, it's a little bit interesting that at 12 months, you see this kind of inflection up. It was significant. Kind of, again, it's a bit unusual that, treatment that's only given in the first essentially 2-3 weeks would continue to have an impact this far out. So I don't know how much we can read into that, but certainly it suggests that potentially something that can have important improvements early on. Maybe it has an impact on the long term in terms of less renal scarring. Who knows? But again, this probably this is more, I'd say, hypothesis stimulating. So if we recap, renal recovery in ANCA-vasculitis, there's maybe an effect of avacopan. It's a bit odd, again, the separation that you see at 3 months. And when you think about it, most patients at 3 months, they're considered to be in remission. So why would it be separating after that? Is it actually because they have ongoing renal activity that maybe we're not picking up? Or is it because of the GC sparing effect and patients are getting less infections? So again, this has to be, formally tested. The benefit from Plex early on maybe translates to a 1-year benefit, although again, it's a very modest impact at best. And the benefit for end-stage kidney disease is really lost after 1 to 2 years. They're also studying this antifibrotic therapy, lixudobart, which is in a phase 2 trial. I don't know if that'll come out to anything. I feel that they've tried antifibrotic therapies for so many things that it hasn't really panned out. But that's another agent that's currently being studied. So, renal recovery, we still don't have a clear treatment to improve renal recovery. There's some suggestion or some possibilities that really need to be tested further for that. This is our guideline on the treatment of ANCA-vasculitis, which is fairly similar to the KDIGO guidelines. We're going to be releasing this, hopefully kind of distributing to the division fairly soon. We're just kind of finalizing things and hashing things out. But we kind of use this 300 micromole per liter of creatinine, a bit like the KDIGO, where you can use where we, let's say, recommend rituximab or cyclophosphamide with prednisone with or without avacopan, and then with creatinine greater than 300, we're typically recommending and doing the rituximab cyclophosphamide combination, but you could use cyclophosphamide alone as well, with or without avacopan if their GFR is greater than 15, so as per the trial. And then in the most severe, to consider plasmapheresis and contact the Plex service. We do recommend that patients get kidney biopsy when possible, a lot of times to have a good idea of the prognosis on the long term. And methylprednisolone really should be used initially for patients with severe GN from ANCA-vasculitis. And now I'll talk about the SAFE-LOW trial. So safe, effective therapy with low-dose glucocorticoid in ANCA-associated vasculitis. So this is a trial that I've been looking to get started now for over a year, and it's really very, very, very close. I feel Deb, I think, knows what I'm going through with Justine and Loren, but it is very close. So I think this is timely that I'm able to talk about this here for a few minutes. So it's going to be a 2-center pilot with Ottawa and Hamilton, and we're in the process of trying to get Hamilton on board with their ethics board. But randomized control trial, open label, 1-to-1 randomization in patients with severe renal ANCA-vasculitis. So it is a renal study and a renal inclusion. And the GFR cutoff is lower than Pexivas. And Pexivas was 50. We're going even lower to 40 mLs per minute. And it's not mandated that they have a kidney biopsy, but a lot of times we are biopsying, but it could be with a urine microscopy. So there is no pulmonary criteria for eligibility like there was in Pexivas. They really have to have a low GFR that has to be acute, so not a chronic GFR of less than 40. We're targeting 36 patients over 3 years. Realistically, 6 to 8 per year in Ottawa, and that's realistic based on Ottawa's recruitment for Pexivas for a similar type of patient population. That's pretty much what was recruited, so I think that's fairly realistic. And the intervention is going to be rituximab with 2 doses of IV cyclophosphamide and 4 weeks of glucocorticoids. And the hypothesis is that we're going to be able to reduce infections while maintaining effective disease control. And, most likely we're going to be able to reduce GC-related side effects. And the benefit of this is also to provide an alternate form of GC-sparing therapy. Rituximab, cyclophosphamide are commonly available agents. And so, whereas novel complement blockers might not be available and might not become available for many places in the world. The comparator is standard of care. So this kind of just recaps the treatments. So you have the intervention group up here. So 4 weeks of prednisone. It's starting off the first 2 weeks is the same as Pexivas. So you're starting about 1 milligram per kilo and then 0.5 milligram per kilo. The difference is that at 3 weeks, you're going down to 10 milligrams, and then at 4 weeks, 5 milligrams, and you're stopping. Whereas in the control, you're having a Pexivas. It's standard of care. It's not mandated. It's whatever, clinicians want to use, but we're using Pexivas. That's kind of the standard of care. So that's the comparator. And then for the induction agents, rituximab, again, it's not mandated, but this is what's most commonly used, the 1 gram for 2 doses. But the cyclophosphamide is mandated 2 doses of IV cyclophosphamide with dosing as per usual pulses for IV cyclophosphamide, adjusted for age and GFR. And standard of care is whatever, the clinician wants to use. So it's Ritux or cyclophosphamide, can base it on, base off our TOH recommendations. Now, obviously we want to, let's say, avoid that everyone gets treated with the combination Ritux and cyclophosphamide, because that might make it a little bit tougher for generalizability, though it isolates the glucocorticoid component, because not all centers agree that, standard of care should be Ritux plus cyclophosphamide. So that's, that's something we've discussed together as the GN group. But basically it's Ritux or cyclophosphamide in general for patients. Now, interestingly, no, we're not allowing upfront avacopan. So that's different for, nephrologists that are on the ward and treating, starting patients with induction therapy. However, avacopan can be introduced later if there are problems for, let's say, resistant disease or GC-related adverse effects. For adjunctive therapies, methylprednisolone, there's no restriction, can use as the clinician sees fit. Plasmapheresis, no restriction. PJP prophylaxis, no restriction. It's just usual care, and we use PJP prophylaxis for all our patients. And avacopan, like I said, no upfront use, but it's okay to use for rescue therapy. So that's if patients get a flare-up of their disease, they have resistant disease or suboptimal disease control, and you want to use something other than steroids, you can use it. And GC-related, or if they have major GC-related adverse events and you want to come off steroids quickly, but you're worried about their disease control. Recruitment, so the majority will be approached, consented, randomized while they're admitted. Vast majority of these patients will be on service at the general. And so, what we need is awareness from clinicians when they're on service. And, I'll be communicating with Mike and I'll be creeping the list on a weekly basis to look for patients that have potential ANCA-vasculitis and to basically alert myself or Mark or anyone from the GN team. As soon as you have anyone that you're suspecting might have ANCA, it could be, we think it might be this, they're planned for a biopsy, still let me know because we have to screen for eligibility and then approach the patient for potential consent. If you have a patient admitted at the general that you're seeing on consult service that's got a new diagnosis of severe ANCA-vasculitis, but they're on medicine, For them to be involved in the trial, they have to be transferred to nephrology. So that's a little bit of a particular thing, and that's because of research pharmacy involvement for the cyclophosphamide and prednisone. So that's, again, I'd argue that those patients anyway should be transferred to nephrology if they've got severe renal ANCA-vasculitis that needs treatment. And of course, for people taking outside calls, if you have something that might smell like ANCA, maybe a lower threshold to accept them because they might be a potential trial participant. The outcomes, so this is a pilot trial. We're looking at feasibility, so recruitment and adherence to the GC taper in the intervention arm. We're also going to look at serious infections, remission rates, change in kidney function and stage kidney disease, death, and also patient-reported outcomes. And like I said, potential benefits is reducing infections, providing an alternate form of GC-sparing therapy. And I'd say that regardless of the outcome of the trial, it's going to give us a better understanding of, the role of GC in ANCA-vasculitis and, this question of how low can we go. It'll definitely provide insights into that. So just some final thoughts here. To me, how best to improve outcomes, decreasing infections and increasing renal recovery. How to do that is another question. And that's why I'm doing the trial looking at the infection part. And there is another trial being planned, headed by Mike Walsh, that he's looking to get started, that will look at the renal recovery potential aspect with avacopan. Now, a lot of people think that I have this agenda against steroids and that I hate steroids. It's not that it should be no steroids. It's more that it should be a more appropriate use. I doubt we'll ever find a more potent anti-inflammatory substance than glucocorticoids, and glucocorticoids work well. They work well when they're given early, when they need to be given for a highly inflammatory disease. So I think that it's appropriate to use them up front with pulse steroids, with high doses early on when you've got a severe life and organ-threatening disease, but that, a lot of times you probably don't need to continue them for very long. And, you're going to decrease treatment-related side effects, which can have an impact on kidney function and, long-term outcomes. Again, there's a difference between pure GC reduction and replacing with an alternative immune suppressant, like we saw with avacopan, didn't have that much a reduction in infections for an agent that you're continuing for a year, even though you're getting off steroids. So maybe less steroid side effects, but maybe not as much of an effect on infections. And more studies are needed on renal recovery. And like I said, there's hopefully going to be more data on this in the coming, 5 years or so, studying avacopan, looking at specifically renal recovery. And, early treatment effects, as we can see with plasmapheresis, potentially can translate to long-term benefits. And so, perhaps that providing a more optimal and more intensive early upfront induction therapy with rituximab and cyclophosphamide combination could lead to longer benefits. I just want to say thank you to the funders that are helping for my research, Vasculitis Foundation, Tahamo Innovation Fund, and Physician Services Incorporated that are going to be helping to fund this the SAFEFLOW trial. Mike Walsh, who's been really helping on kind of mentoring me and guiding me and helped a lot in getting the funds and support for this trial. Mark, who's helped a lot in the protocol development. And in particular, Justine and Loren, who have and continue to work with me really hard on getting this trial started. So thank you, a huge thank you to them. And I'm going to continue working with them throughout the trial. And so I'll open it up to any questions.
Right. Thanks. There was a lot of data. So
Yes,
we have 1
yeah.
minute for
Sorry.
questions. Maybe we can escape briefly. Yes.
Just want to highlight about the trial, the 2 research coordinators that we have themselves available weekends, so that we don't miss anybody, given a small number of patients that we might actually have access to. So obviously, if you're on service A and we might be able to recruit somebody on a Friday, that would be awesome, instead of waiting until a Saturday or a Sunday. And then the only other question that I've got to run for a meeting, but I don't see in any of these, is there any kind of role for things like strep pneumo vaccination in the prevention? They're on mega drugs at that time. I don't know if the vaccines have any efficacy, but I don't see that as part of our protocols in reducing infection.
You're right, it is. The French group, they looked at this with upfront vaccination in patients. They looked at more kind of the response to treatment. They didn't look at long-term outcomes. That was presented, that was kind of preliminary data, so I don't know if they'll have more data on that. But there's someone looking at that. The response rate is the big issue because they're heavily immune suppressed early on. So it's a lot more kind of preventative and just having patients with CKD vaccinated or older individuals vaccinated.
So it's 9 o'clock. So if people want to leave, please go ahead. We'll hang on for people who want to stay and are excited about vasculitis to ask questions. There are some questions in the chat, but let's go with Anne and then Greg.
Thanks for a great talk, David. I just have a question as we have somebody at the Civic on Service C with a high MPO titer and we're awaiting biopsy. And I thought you said something a bit conflicting between the trial protocol and what you might be sending out to the division. So in her case, she has a creatinine of over 300. Can I go with Ritux 1 gram and low dose cyclophosphamide? Or would you prefer that we not, like, I wasn't sure if you want to use combination therapy or not.
So for, I'd say the trial is going to be, you're right. In the trial, we're going to be, I guess, somewhat recommending that something different be done than what our, let's say, protocol or guideline is going to be.
Mm-hmm.
This patient, if they're not going into the trial and they're not because it hasn't started yet, using rituximab with the 2 doses of cyclophosphamide would be something that we would recommend. But if you had this patient that was enrolled in the trial, well, then probably, again, if there's a really compelling reason that you don't want to use cyclophosphamide as the sole, IV cyclophosphamide as the sole induction agent, then you can use Ritux and cyclophosphamide. But we just don't want everyone in the control group to end up having the combination because that becomes an immediate, let's say, criticism about generalizability. However, just cyclophosphamide as a sole induction agent for patients with severe renal ANCA-vasculitis is an option. So it's the combination and also the possibility of cyclophosphamide as a sole agent.
Yeah, you might just want to think about that if you're going to be starting the trial and releasing the protocol around the same time, because I think that could generate some confusion for you.
Yeah, and in the, I should have actually updated it, but we had discussed this with Mark that in the over 300, we'll give the option also of, Ritux cyclo combination or cyclophosphamide alone.
With a lower dose prednisone.
Yeah.
Okay, thank you.
Greg?
I guess, thanks, David. I guess I would take a different angle. Like you've got a relatively, from a trial design perspective, you're going to have a relatively small study, right? Like I know it's a pilot, but even in the big picture, it might be a relatively small study. And you're trying to answer one question, but yet you're by chance, you're going to have a lot of variables that are different between the groups. So when you leave this open for generalizability in a small pilot, you're actually, I think, maybe creating more problems because you're going to have probably an imbalance of induction. You're going to have imbalance in plex use. You might have an imbalance in dose of methylprednisone use. So the way I would flip this around and say, you want to tighten this up totally so that you have everything the same except for your question at hand around steroids, because this is not really a pragmatic trial at all. And you shouldn't be trying to do both. So I'm sure you guys have talked about this, but why did he decide this? Because I can see you're going to have like 40 patients, there's going to be an imbalance in plex, and then you're going to say, well, maybe it was the plex, they got the better outcome here. So how did you decide to do it this way?
That's a great question. We went through a lot of discussions and presenting at conferences and getting input from others. And, it was impossible to find a consensus because every way you looked at it, if you tightened it up and really isolated the steroids, no one would agree as to what, would be a standard treatment. And then when you looked at also the regulation aspect of it, with it having to be a Health Canada regulated trial, this came out as let's say the most easily acceptable and the most realistic to be able to do. And I'd argue that what we're looking at here is reducing infections. And it's true that all these other therapies might come, I guess, muddy the water a little bit there. But if we're able to show that we can use less steroids with this combination therapy and, less steroids, and that it's feasible and that patients are actually able to do the treatment and that they do relatively well, well then, a lot of that, yes, we might not be able to see a superiority or what, but I doubt we're going to see, if we can show that they do as well, already that is huge. And so maybe we adjust the protocol when we're looking at expanding it further and growing the trial. But there was a lot of discussion about this, and it was impossible to get a consensus. And we just finally decided that that's the best.
I guess what I'm trying to say is if you do show that they're doing okay, it might be due to other reasons in a small study. And I think you're going to be left with that problem. So I don't know. I'm just trying to think, look down the road to your analysis and think.
If they do well on 4 weeks of steroids, no one's going to doubt that. That's huge. Like it's not, that's unlikely.
No. I'm saying you might have imbalances so that your arm might have all the patients got plex by random chance in a small study. And then people would say it was the plex. I'm just saying you've got a small study. Yeah. It's a study design question. You're going to be faced with an interpretation issue at the end, I think, by chance. That's all. Anyway, it's a philosophical question because it's not a large pragmatic trial where all this stuff kind of balances out in the end. It's not. It's not going to balance out in the end. Right. That's all. Anyways, congratulations. It's good. It'll be an interesting trial.
Thanks, sir.
So a couple of comments or questions in the chat. One is, of course, from Dr. Ian Brampton, who's saying, why shouldn't you involve community centers? So I guess when you get funding from CIHR, you can approach Dr. Ian and make sure you enroll patients from there.
I shall knock at your door for sure. That is the plan, yes.
We do have a dedicated GN clinic. And I think we do have a higher incidence of ANCA-vasculitis for some reason. It's some geographical thing or genetic thing, I don't know. But you will find a lot of patients for this trial from our center, and it will be very easy to track. We have a dedicated team of nurse practitioners, 3 physicians, pharmacists, and social workers. So I think it will be very easy to recruit if you ever decide to contact us.
Fantastic. It's great to have that interest. Thank you.
And Gina had a question about the risk of increased infection. Do you think has it been separated for patients on dialysis versus not on dialysis? Because it just may be that people on dialysis get infections because they're on dialysis.
Yeah, that's a good question. No, I haven't seen anything that kind of separated it to that level. The only thing I can say is that when you look at Pexivas versus other trials, highest rates of infection were in Pexivas, about 30% serious infection rates, and they had the worst, kidney function. So we know in CKD in general that worse CKD, higher infection risk in general CKD. So I don't know if it's all driven by dialysis requirement or not. Obviously, I'm fairly certain that if you looked at dialysis requiring, you'd probably have an even higher rate of infection. And a bit that meta-analysis from BMJ, where I showed that table of risk-benefit trade-off of Plex, while also the serious infection rates go up the higher your baseline kidney dysfunction. But I haven't seen anything that's teased out dialysis versus non-dialysis in the ANCA trials.
Perfect. Thanks again, David. And if there are no other questions, I'm sure people have questions, so you know where to find David if you have any questions. But congratulations again on getting your trial off the ground. The hard work is ahead of you.
Yeah, oh, really? Gets harder, okay.